Hello, everyone. Welcome to the webinar, Is My Patient Ready for Hospice? We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Throughout the program, please type in your comments in the chat box and select all panelists and attendees for the to box. If you experience any visual or audio difficulties, check the chat box for instructions or dial in directly to join the webinar by calling the number in the email you received upon registration. Our webinar will begin at 12 p.m. sharp. Please take these last couple minutes to get settled and get ready to enjoy the webinar. Hello, everyone, and welcome to our webinar, Is My Patient Ready for Hospice? My name is Lauren Blair, and I'm the Provider and Community Relations Manager at Coastal Hospice. Welcome to our Caregiver Academy. We're excited that you are joining us today. Among our attendees today, we are happy to see many familiar faces and organizations with us. We have colleagues from Tidal Health, Care Patrol, Riverside Health System, Worcester County Commission on Aging, MAC, and full end-of-life doula services, the Worcester County Health Department, among many others. It's wonderful to see all of you today. Before we begin, allow me to go over a few housekeeping items. My role today is to help facilitate and handle the behind-the-scenes logistics of the webinar. You may see myself or my colleague Alejandra pop in the chat box to address or help with any technical issues. I want to thank you in advance for your patience should we have any. I'll also come back in at the end to discuss the program evaluation. We ask that you set aside other devices or work for the next hour. We are sure you will enjoy our program for today. To make this interactive, we may ask you some questions from time to time. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. When you send a message, please be sure to select all panelists and attendees for the to box, so we can see your comments and questions. Our webinar today will be moderated by Monica Escalante, President of Coastal Hospice, and we have invited two experts in end-of-life care to talk to us about when a patient is ready for hospice care. Monica has more than 20 years of experience in end-of-life care. She is a board member of the Hospice Network of Maryland and a diversity advisory board member of the National Hospice and Palliative Care Organization. Monica, I'll hand it off to you.
Thank you so much, Lauren. We're really happy that we have so many clinicians in attendance today. And our goal for the presentation today is for you to know if your patient is ready for hospice. And I have two wonderful presenters with me, and I'm going to let them introduce themselves. Dr. Ghulam Waris.
Yes, thank you for inviting me, and it's a pleasure and an honor to be here to discuss end-of-life care and hospice with all of you. I graduated from Seton Hall in 1995 and then worked in Bronx, New York with Bronx Lebanon Hospital and St. Mary's for a few years before I moved to Illinois as a private practitioner. And then in 2002, I moved to Salisbury, Maryland as a primary care physician. My background is internal medicine, and when I moved to Illinois, I did geriatrics. And then when I moved to Maryland, I got involved into hospice and palliative care in 2017, and then got certified in hospice and palliative care. And I've been with Tidal Health, palliative care, and hospice, Coastal Hospice since then.
Thank you, Dr. Waris. Dr. Joan Carpenter, can you introduce yourself?
Sure. Good afternoon, everyone, and thanks for being here. So I'm a nurse practitioner and nurse scientist. Most of my practice has focused on caring for older adults in long-term care, short and long stay in nursing homes. And I joined Coastal Hospice in 2010 as a member of the palliative care team. So I've worked in the inpatient setting, the outpatient setting, home hospice visits, and in providing palliative care consultations in the nursing facilities.
Thank you. One of the reasons why we decided to do this webinar today is because we've observed that many patients that in the past were under our care for 2, 3, 4 months, in the last 6 months have been under our care for about 1 or 2 days. And we want to entice everybody to look at different indicators to know when their patients might benefit from having this wealth of services that we offer. So the objectives for today's presentation are first to recognize the importance of establishing goals of care and why that matters in every conversation with your patient, to understand what hospice is and what we can do for the patient, the family, and the caregiver, to identify tools for prognostication and to determine hospice eligibility, and to discuss different strategies that you can use. Put some tools in your toolbox that you can use when necessary. Feel free to use the chat box. I'm going to be monitoring that. We want to make this presentation as interactive as possible. So I'm going to start with our first slide about what happens when someone is dealing with a serious illness and the practitioners can see that it's not going to be curable. Dr. Waris, what do you recommend to the practitioners that are in attendance to do at that point?
Yeah, so this is very important, and it should be revised on each acute event and annually in their physical. When somebody faces fatal disease or incurable, the first thing you need to sit down with your patient and talk about what their goals are. And the way you start that conversation, which is a difficult conversation, especially for primary care physician and specialist oncologists who are taking care of their patients for a while, you have to be empathetic, compassionate, and sit down with the patient close by, turn out your audio devices, and then have a serious discussion about. First thing to ask basically is, what they understand of their disease. That's when you realize that most of the patients really actually know what's going on. But then the second thing would be what their goal is, what's important to them, and what would they want to do the rest of their life.
Thank you, Dr. Waris. Dr. Carpenter, what is the difference when someone dies at home as opposed to anywhere else? Why are we advocating? Studies show that most people want to die at home, but despite that desire, most people don't.
Right, I know it's this is quite the question, is why do so many people still die in inpatient hospital settings and in nursing homes, nursing facilities, when most people are saying they want to die at home. And, to Dr. Waris's point, having conversations with people, not just about the treatments they may or may not want for themselves, but how they want to spend their time is really important. And I think as clinicians, we tend to focus on medical treatments and therapies and what we will do in a way that's reimbursable for our patients, as opposed to talking to them about what it is that's important to them and how do they spend their time and how do they want to spend their time. I think once we can start having those conversations earlier during serious illness, we can really help people spend their time at home when that's what they want to do. We spend so much time treating illness and acute events in the hospital that's where many people spend the most time at the end of life. And I think until we start changing our practice as clinicians and our focus, we're not going to change these numbers.
Right. I think one of the issues that we don't talk enough about is, what do our patients do when they come to hospice care? What do they have time for? What do we offer them? What are the wishes that they can realize when they have time to do that? Dr. Waris, you want to talk a little bit about that?
Yeah, so when we've seen that over and over again, when the focus is towards comfort and spending their rest of their time with family and friends, people actually get better. their quality of life improves, and the distress and the anxiety and tension of the family and the patient has a tremendous effect. And hospice works as a team and they take care of a patient as a whole, not just hypertension, diabetes, monitoring INRs and things like that. They take care of the existential, spiritual, psychological, and the whole person as a whole, and that demeanor just changes everything. So it is documented that patients who use hospice earlier than late have a good quality of life. The caregivers have less distress, and they're more satisfied.
One thing that I know happens with frequency is that we discontinue some medications because it's the first time that one doctor is looking at all the medications that the patient is taking, the ones prescribed by the cardiologist, by the oncologist. Can you speak a little bit to that?
Yeah, so polypharmacy is really an issue, especially in the elderly. If you look at the statistics, people who are in the nursing home average take about 13 medications a day, and they all have interactions. And when they're coming to a point where they have multiple diseases and they have less oral intake, and a lot of these medications, instead of doing good, they do actually suffer more with more interactions and side effects. So when we try to de-escalate some of the medications and try to do less and less of polypharmacy. So when you do that, people actually get better because they don't have all these side effects.
And research shows also that they can live longer if they use our services not within the last 48 hours of life. So what is a good death?
Yeah, so if you look at the definition of the good death, is a good death is one that is free from avoidable distress and suffering for patients, family, and caregivers in general, accord with the patient and family's wishes, and reasonably consistent with clinical, cultural, or ethical standard. That's the definition. But what do patients and doctors get out of this? The patient's definition of good death is they want is to be quick, painless, and peaceful. We all do. And what do physicians' definition of good death is? They want their patient to be free of pain and anxiety and pass with comfort. And that's what we do in hospice.
Exactly. But there are different ways to approach these at the end of our life.
Yeah, so I will go over the four death trajectories that are, in the 1990s were clarified, and usually there are four different ways of four different trajectories of a disease that can happen. Number one is sudden death. This is that we see in let's say a certain cardiac death, and a ruptured aneurysm, accident, or drug overdose. Unfortunately, not a whole lot of preparation or support can be given on this type of trajectory because there's sudden death. Now, the second one is terminal illness, and that's where if you see the cancer comes out. This trajectory, once they, patients who are stage 1, stage 2, stage 3, they're taking cancer treatment, but they come to a point where their treatment is not effective and their disease progresses. So then they go to a steep decline and pass. Now, in this condition with cancer and this illness, palliative care can be started from the day it's diagnosed. And when they stop responding to treatment, or some people refuse treatment, then they should be, when that steep decline comes, should be referred to hospice. If you look at the third one, it's organ failure. That's where a lot of COPD, congestive heart failure, chronic kidney disease patients fall. And we all know what happens. They get recurrent admissions, but they come to a point where every time they get admitted, they get better. Like with let's say COPD exacerbation or congestive heart failure exacerbation, they get better, but they never come to their baseline and they continue to decline. So in these conditions, palliative care should also be started from the day the chronic diagnosis is established. And when they come to a point where, the physicians think that, their life expectancy is 6 months or less, then they should be referred to hospice. The fourth one is about, move the slides a little bit. Okay. Actually, that's chronic illness. And in that trajectory, we see Alzheimer's disease, Parkinson's, some neurodegenerative diseases, multiple sclerosis. There is a slow decline. And let me tell you about, and talking about Alzheimer's disease, dementia, most people, the average life expectancy is 4 to 8 years from the day diagnosed, but people can live for 20 years. So, some people can live for 20 years from the diagnosis. So this is where a lot of support is needed for caregivers. The largest caregiver burden in US is with dementia, Alzheimer's, Parkinson's disease. And there, when they come to a point where they're total care and not functionally declining with weight loss, then that's where the hospice comes in.
Yep. And we offer a lot of support for caregivers as well. Dr. Carpenter, all of the graphs are together in this graph that we have in front of us now. Can you help us understand how can palliative care and hospice care help within these trajectories?
Right, so this is a busy slide, but I do like it because I think it allows you to compare these different trajectories and think about where does palliative care play a role in different illness trajectories. And I, always tell people palliative care is for any age and for any stage of a serious illness. You don't have to be in a certain, stage of cancer or stage of serious illness to be eligible for palliative care. And remember that hospice is always palliative care, but palliative care is not always hospice. So what I'm saying is that hospice and palliative care are distinct, and hospice is a way to deliver palliative care. But what I like is that palliative care is started here earlier than you see at end of life care. So think carefully about how you can identify a person who is exhibiting decline in their illness, and when you can start introducing hospice care along with palliative care. In this graph, though, if you look at the palliative approach, plus or minus active treatment for advanced disease, palliative care is delivered alongside potentially curative treatments and aggressive disease modifying treatments. So many times we can transition people to hospice from palliative care as they approach that 6-month life expectancy. The trajectory 2 here, I think, and trajectory 3 are important to look at because each time you're seeing a decline in a patient offers you an opportunity to have a conversation about their goals of care and about how they're doing. So you can help them think back, how have you done over the past 6 months? How have things been going? What have you noticed that's changed? And when you start that conversation and they're able to verbalize and their family's able to verbalize how their life has been, how their quality of life has been, how their symptom management has been, you can start to introduce the conversation about, hey, let's think about some ways that we can help you manage your symptoms and help you manage your disease in a different way, because we're in a different place now than we were 6 months ago.
Right, and along those lines, where do you start, Dr. Carpenter? Where is the beginning?
So many times I start by asking people what they understand about their illness and what they've been told. And many times they say, I don't know. And despite having a medical record that says that the diagnosis was discussed at length with the patient and the family and all questions were answered, many times we give too much information at once to patients and their families, and they really don't digest the information. So I ask what they understand, and we start there and say, okay, how much do you know and how much do you want to know? And every time I give someone a piece of information about their illness, I ask, now, can you tell me what you understood about what I just said to you? And once I determine, and any clinician determines, I think that they have an understanding of their illness and the trajectory, then we can start saying, okay, now that you know this and you're understanding it, what's most important to you and the time that you have, and how you want to live your time, your remaining time.
Do you find that sometimes takes more than one conversation, that people need time to process the diagnosis and what is happening. So probably if you start that conversation about palliative or hospice care too abruptly, you might not give time to the patient and the family to process.
For sure. And I think that's where we get back to, it's so important for primary care clinicians to have these conversations earlier with their patients with serious illness, and to not wait, because the conversations do take time, and it does take having multiple visits, I think, for a person to really gain a deep understanding and a really meaningful understanding of their illness. What do you think, Dr. Waris?
Yeah, so exactly. So every time, primary care physician has to get involved. And, the healthcare in US is patient-centered right now. And that's what palliative care is. Primary care physicians are usually the first one. They have a relationship, a rapport with their patients. So it's the best way to get this conversation started is when patient is not in the emergency room or in the acute care setting. It's in the clinic where they are seeing patients on a regular for annual physical, or every time they have an acute illness and they get out, they're getting to the hospital, coming back. And if they're declining with frailty and debility, that's where the discussion needs to happen. And you need to recognize the importance of truth telling. We need to be straightforward. I know a lot of physicians, we are trained to take care of our patients and keep them healthy and alive at all time, but we all know that that's not possible. There comes a time when the disease is not curable. So we have to be forthcoming and be truthful to our patients, and it becomes easier because the patients trust their physicians. So we need to show, importance to that trust and bring this up. And one thing that I really have seen in this era of technology, we have cell phones, we have laptops, we have to record everything. We come in and we don't really pay attention. But when we do palliative care, we stop all those, we leave those equipments out. You're supposed to sit down, take a chair, not just stand. I've seen several times, attendings just going into the room, standing on the side and talking to the patient while they're on the phone or where they're documenting on their laptop. I know we have to do all those things, but these are serious conversations. So if you show some empathy and compassion, you get better results. But as Joan said, this is a conversation that has to happen all the time.
And also I'm thinking here, for the patient to understand what the preferences are, it takes time for any patient to come to terms with what they no longer are capable of doing, because I imagine the default is always to go back to being able to do everything. And then from then you have to adjust to what is possible now. And that takes time. And sort of thinking, what is quality of life right now, given where I am, if I have a serious illness? It's a process. Can people verbalize that in consultations, Dr. Waris?
Most people do, but you have to take time. And as you said, it's repetitive. And I'll tell you an example. There was a patient in the hospital I saw, and after a few minutes of discussion, I asked him, what's important to you? What would you do if you figure out? And his answer was, I want to go fishing with my grandson. Well, in 2 days, he signed up for hospice and went to inpatient lake at the lake, and we made that happen for him. I mean, that was his wish, and it happened right at the lake at Deer's Head Hospital Center. We arranged for a boat, and grandson came and he went fishing. That was his wish. That was the only important thing. He didn't care about hospice, symptom management, or anything. So you really have to ask that question. What's important? How do you want to spend your rest of your life? Sticking to these machines or stuck with all these IVs, which are not actually making you worse? Or would you rather be home with your grandson or grandchild or your daughter or your son and spend, or your loved one, and spend the rest of your time enjoying that time?
So we give patients and the families time to fulfill those wishes they may have.
Yes.
With their loved ones, which doesn't happen when you don't have enough time to do that. So we're talking about truth telling here, and we have a photo of a patient who is a patient of Coastal Hospice who wanted to ride that bicycle, and we made that happen for him. So medications were adjusted so he could enjoy that as best he can, or he could at the time. And that's part of what we talk about of being truth-telling. Dr. Carpenter, what do you find might be helpful for other doctors who are protecting their patients by sort of tiptoeing around the truth? What do you find works?
Well, I think we have to realize that it's somewhat paternalistic to not talk to your patient about their illness and what they want to know. We assume that we know what they want to know, and we really have to be asking them what they want to know, and what's how much they want to know about their illness and who they want involved in the conversations. And I think we're worried that when we tell people that they have a serious illness, that they have a limited life expectancy, that we're going to somehow hurt them, or we're going to somehow do something that's going to be harmful. And there's no research that shows that that's true. It's more important to ask a person. I mean, they know, many times people know that they're seriously ill, in these situations where, and I've had it where, in one particular situation where it was a married couple who had been married for 60 years. And the wife didn't want to tell the husband how she was feeling. The husband didn't want to tell the wife. And so I went to each of them separately and said, how about if I help you talk together? How about if the three of us, and that was very satisfying for both of them as an approach to help guide them through having a conversation that was honest and frank and direct about this serious illness that the husband had, and what were going to be their plans going forward, because time was limited. And I told both of them that, having this conversation is going to help you make a decision about how you want to spend the remaining time that you have. And is that going to be in the hospital, or is that going to be at home? And I found that, when you do this in a way that's thoughtful, and you're thinking about people's emotions and reactions, and giving them the space to be emotional, and giving them the time to process the information, it's very effective, and we aren't causing our patients harm by truth telling.
Thank you. So we want to give the attendees today some tools for their toolbox as to actual language that might be useful to use. So I'm going to turn to Dr. Waris as to what exact words do you use? Sometimes people want to know exactly that.
Yeah, so when we start this conversation, the first thing that we try to ask is what you know about your disease, and what has your doctors told you about your disease. And studies have shown most patients really actually know what's going on. They don't want to talk about it. So, but if it has to take, you have to take that approach and let them tell you the story, and ask them what's been happening over the past few years, depending their functional status. Like, when are you able to go on a jog anymore? Are you able to enjoy going out? Are you even able to get out of bed? All those things, and that make patient realize how bad their functional status is declining or not, and then we asked, what's important to you right now? Is the most important thing is to stay home and go out with your family and enjoy dinners and lunches and ice cream, or would you rather go back and forth to the hospital? And then you ask, involve their loved ones, what their wishes are, and you go from there.
What are their fears? Because I imagine the patients must have lots of fears that they are holding on.
The number one fear of patients who are dying is actually pain and anxiety. Okay, nobody wants to die in pain, in distress. shortness of breath for patients who have COPD or congestive heart failure. A lot of those symptoms are very well controlled. And in a study that was done for hospice, we are able to control up to 90 to 95% of those symptoms right in patients' homes. And when we do that, they can get things done. They can do stuff with your family, and so that's as far as you take care of the symptoms. And if you look at the data that we can share with the hospice satisfaction rate is in the 90s.
That's very high,
Yeah.
high success ratio with the management of anxiety. Because I can imagine as I'm trying to walk into the patient's shoes, which is absolutely impossible, but at least I'm trying for a second here. I think there must be a lot of unknowns, uncertainty, and as clinicians want to take the time to alleviate some of that. Dr. Carpenter, talk less, listen more. What strategies do you use with your patients to go over even advanced directives? Have they appointed someone to speak for them if they can't?
So a couple of things that I was thinking about. One, the fear of the unknown that you brought up, just to think about this, is that one thing that we help with in palliative care and hospice is to help them. This is how we're going to help you manage the symptom. So I think what happens is you only do this once, right? We only, if we're a caregiver for a person dying, we may only do it once or twice in our lives as a family caregiver. As a person going through serious illness, we do this once. So I think the idea, that people, there is an unknown, and they want to have people typically want to have some help knowing what to expect, if that's, part of their goals. So I think that's really important. The other thing I wanted to bring up is that talk less, listen more is so important, because we tend to talk over our patients, and we tend to not listen to them and then guide the conversation based on what they tell us. So one of my favorite ways to talk to people about serious illness is talking about how things have gone over the past 6 months or year, and then taking that and saying, well, we're in a different place now, because now, you were doing this type of activity 6 months ago, where your symptoms were managed so well 6 months ago. Now we're in a different place. And so therefore it opens up the conversation about, I think it looks like things are getting a little bit worse. Your illness is progressing. How now do we want to treat your symptoms and treat your illness? And is it a time where we need to be having more discussions about hospice care and learning about it? So I think here, have you written your wishes down? One of the most important things to me is that people have a designated person that they trust to make their decisions for them if they are unable to do so. That to me is actually, and I don't want to cause any controversy, but it's more important to me than actually having all of those decisions written down, because we know that people's goals and preferences change over time during serious illness. I have an advance directive. It's written in a certain way based on where I am in my life, where I was in my life when I wrote it. Now, in 30 years, or, it may be different. So I think it's more important for me to have a person that knows me very well and knows what my goals and my values and what's important to me to make those decisions if I'm unable to do so. And I think part of the reason I advocate for that is so many of the patients I work with have cognitive impairment and progressive illnesses that will lead to where they cannot make their own decisions. So it's important to me, that people have had these conversations with a trusted person, have appointed that person to make their decisions. And so that's where I tend to spend a lot of my time.
That's incredibly important, to appoint someone who will be able to show up if needed also, because I remember there was one case when the person that was appointed couldn't be found at all. So probably at least one person that knows you well, if not two. We have a question from the audience, and it says, how do you deal with patients and doctors' resistance to the word hospice?
Yeah, so there is the first thing that needs to be done with that is, as I mentioned, doctors are trying to keep their patients healthy and alive because that's what we are trained to do. Okay, well, so, but not a lot of new doctors who are coming. The previous doctors had never had this training about palliative care and hospice, but a lot of the new doctors now who are coming out of training have this training already, and they understand when to call hospice and when to call palliative care. But that's why we are having this discussion. So we're going to have more and more of these discussions, and same thing with patients. We are going to do more and more of community training and approach, and try to take away those myths about hospice.
I also like to ask people what they think hospice is, because it's fascinating the answers you get. I mean, hospice is a place. Hospice is, it's and so what if you find out what it is that the resistance to hospice is, it may be that they had a family member who had a negative experience at some point with, something, that was related to hospice. So I think if we can find out what it is that there is a resistance around that topic, or about, and then we can clarify, well, let me, can I explain something to you, or let me help you understand what we do as hospice providers, or we do as palliative care providers. And I always tell people palliative care is an extra layer of support for people with serious illness, and that hospice is a way to support people and who have a life expectancy of 6 months should the disease run its usual course. And so I think if we can find some standard language and some common definitions for these concepts, that we can help people maybe lose some of that resistance to them.
Right, and we're going to touch a little bit more on the exact services that are provided, so we can try to link them as how they benefit not only the patient, but the entire family and those caregivers. I was reading a study last week that caregivers during COVID, any burdens that they had got accentuated so much more. And the average time of a caregiver is about 4 years. That's a lot of days caregiving and support needed in the home. So what we have in front of us, and I'm monitoring the chat box, there's some activity there. When is hospice appropriate? And Dr. Waris, walk us through this.
So so the hospice, according to the Medicare regulations, hospice can be activated in any patient who has a life expectancy of 6 months or less, and that has to be certified by 2 physicians, so usually the hospice medical director and the primary care physician. But tell you the truth, hospice originated in England, okay, and in Europe there is no prognostic month time period, because it's very hard to prognose when a person going to die. It's not in our hands. So this is a Medicare guideline in US that we have to follow. So anytime, I usually ask as a primary care, you have to ask yourself a question. Would you be surprised if this patient would be alive for 6 more months? You ask that question because you're treating that patient, someone who's coming to the hospital every 2 months, getting admitted and treated for their chronic illnesses. They're not responding to their cardiac or pulmonary medications or cancer medications, and they continue to progress. That's when you need to think about hospice. So that we have several patients who live beyond 6 months. We have patients who've been with hospice for a year. So after 6 months, if they continue to decline in their functional weight loss or things like that, then we actually recertify them every 60 days. So that's what hospice regulations are.
Mm-hmm. So patients can be under our care for more than 6 months if they continue to decline. Yeah. We have also a fair amount of patients, over 100 a year, that we discharge because they are stable, because whatever crisis brought them to hospice got stabilized and resolved. And that has to do with the teaching of our clinicians in the home. They are really providing education those caregivers need so much. I want to talk about the chat box. There's a question. What about frequent hospitalizations, ER visits? Is that a criteria for hospice?
Yeah, we're going to go over that. But yeah, one of the criteria for calling for a hospice is somebody with chronic illnesses. And, anytime they have more than 2 to 3 admissions to or hospitalizations, we should think about hospice. As we looked at the trajectory in the chronic illnesses, every time they get admitted, they never come back to their baseline. So when that's happening and people are getting readmitted frequently, then yeah, that's something that needs to be addressed. And the best way to address that is asking patients what they want, and do goals of care and advanced directives.
Right. And speaking of advanced directives, on the chat box, we have Gigi has announced that she's a health nurse coordinator, and she did palliative care in the past, but she's also offering a monthly webinar on advanced directives mold, and that's on Tuesdays from 1 to 2 p.m. And we're gonna, Gigi, we are going to connect with you because we also want to share that information with other people within our organization. Thank you for putting that in the chat.
And that's an excellent way of starting this conversation.
Mhm.
But as you look at the statistics, only 24% of Americans, they talk more to their kids about drugs and safe sex than end of life.
Yeah, that there's room.
So that number needs to improve.
Yes. And so when we talk about hospice, the philosophy of hospice, we have this diagram in front of you to help us explain the interdisciplinary team that comes to the home to offer support. And I don't know, Dr. Waris, you want to take this one, Dr. Carpenter?
Yeah, so the hospital works as a team. As I mentioned before, we treat the whole patient. We not only focus on pain, anxiety, depression, and all those things. We focus on, and I'll tell you an example. We had a patient in our inpatient facility who we were controlling pain, and the pain was not getting better. And finally, I said, we're giving him so much pain. There's something else going on. So I talked to the pastoral care service and said, find out what's wrong. Well, one of his nephew was in Iraq, and he hadn't seen him for three years. So he was in this existential suffering. That pain was not getting better. So we arranged for the nephew to come back to visit him, and his pain got better. So it's not just, you don't focus in hospice. We don't only focus on physical symptoms. We focus on psychological, spiritual, and we treat the whole body. And that's why we use a team. The team consists of direct care staff who go to their house and take care of them, a nurse, a physician. We do home visits, OT, PT, speech therapist. We talk to the dietitians. We have spiritual care, and then we also have bereavement. And so, and the team not only just work with the patient, it's available to the whole family.
Right. So a large number of people that are in supporting the families and the caregivers. So these are the services we provide. I'm going to turn to Dr. Carpenter to help us explain some of these services.
Right. So, I mean, I think what this really comes down to is wraparound. We really wrap around the patient and the family and the caregivers to provide the best care possible at the end of life. And I think when you think about this, there's the tangible pain and symptom management, of course, as well as the emotional and psychological and spiritual support, the medical supplies, the equipment. People don't realize that many hospice patients have durable medical equipment needs that are paid for through the Medicare hospice benefit. That means a hospital bed, a commode. I've even seen some people use the trapeze in the bed, as well as a Hoyer lift. If we can train the family in using these types of equipment, then it's provided. If they need a speech therapy evaluation or speech language pathology evaluation to decide, what kind of, foods might be safer to swallow than others, as well as inpatient care whenever there's a crisis and symptoms. There's the hospice inpatient unit where people can go to have their symptoms managed, as well as respite care when a caregiver needs to have maybe a break from caregiving or has their own healthcare needs. As well as bereavement care and counseling. I think that we underestimate how much a family needs after the loss, families and friends need after the loss of a loved one. And one thing I think that's really important that hospice provides is COMPASS, which is support for a person after they're discharged from hospice services. So there's a person that is still, there's a hospice representative or employee who's still checking in on that person after they're discharged from hospice services, because many times we do see, and almost in many cases, we see the people decline within 3 to 6 months. And so we can bring them back on to hospice services when we see that it looks like their disease is progressing. So I think, that access to 24-hour, a nurse 24 hours a day is important. I mean, whenever people find out that they have access to a healthcare provider 24 hours a day, it makes them feel so much more comfortable. And it takes away some of those unknowns. How am I going to deal with this? How are we going to move forward? We help with that in hospice services.
Yep.
One thing I want to interject here is that, hospice is also a self-referral service. So you don't really need a physician to refer to hospice. We get a lot of family members who have seen their loved ones before in hospice. They would do self-referral, and then we approach the primary care physicians and say, look, we have a request from the family, or there are patients who don't have a primary care physician. So we go out and evaluate them. That's one thing. The other thing is, if you're not sure, or if the patient is not accepting hospice, you can always ask for an informational visit from our staff. So our staff nurses or people from COMPASS will go to the house and talk to the family, explain to them what's going on and what hospice can offer, and that's available.
Yeah,
free of charge. There's no charge for that.
Exactly.
So as a practitioner, if you're not sure, if you think family is not ready, you can always ask for an informational visit.
Yeah. And who pays for hospice? I also want to make sure for the practitioners that are attending our webinar today, sometimes the doctors feel that they need to relinquish the patient to our doctors on team to refer them to hospice, and that's not fully necessary. The attending physician can continue in that role and can still get paid with a modifier by Medicare if they continue to be involved in the care. And our doctors, including Dr. Carpenter, Dr. Waris, will continue to collaborate with that attending doctor. And that could be our oncologist, that could be the primary physician. We collaborate, and Medicare allows for both doctors to get reimbursed for the care they are providing.
And then a lot of patients think that they're going to give up their specialist, and no, we let them go to see their cardiologist, especially if their diagnosis is cancer and they want to go to see their cardiologist. The cardiologist can continue to see them and bill for those services.
Yep. So we have a question here. Gigi saying, I have multiple patients who are not willing to give up dialysis or tube feeding or oral oncology drug that would be expensive. So it makes them ineligible for hospice care due to the cost of these treatments. Some are very close to death, and some have died before electing hospice. I wish reimbursement allowed for some of these continued therapies. Will this change someday?
Yeah, the CMS is doing a pilot program right now, and a lot of private insurances are hopping into that too. They've already started doing that. We have few private insurances that will accept hospice with aggressive care, even dialysis. So this is in the works, and hopefully will happen soon.
Sure, and it's also part of this new trend that is national, which is the Medicare Advantage plans. So there's some forecast that in the next 10 years, over 80% of all Medicare beneficiaries are going to be in some form of Medicare Advantage plan. And that the Advantage plans that we've seen so far pay for what it's called concurrent care. So there is a lot of hope that both treatments, both options will be able to be available to patients. Dr. Carpenter, do you want to?
Well, that's, you brought up a good point, Gigi, and exactly what Monica said. This is called concurrent care. And actually the VA healthcare system does this. And the requirements for hospice within the VA healthcare system don't have the 6-month time limit. And I think when we have more demonstration projects within Medicare, and this is actually where a lot of my research lies on how do we expand palliative care services and potentially show that we can improve the quality of life and the care that people are receiving, and as an effect, reduce costs. People with serious illness, and serious illness will always cost money to treat. And so we probably have to stop talking so much about money and talking about the care that they want to receive, and then see that the way when we deliver care that people want and the best care possible, the financial piece follows. And I think that one of the challenges is the Medicare hospice benefit has not changed since really its inception. And this has been a huge issue around, people being eligible for services, and how can we influence that change. And I think it's on value-based purchasing, exactly what Monica's talking about, and incentives around how do we improve the quality of care, and then hopefully have people electing hospice services earlier because they're receiving the care that they want.
Thank you. And those are excellent questions. I just want to make sure the audience understands that when we have a patient under the hospice benefit, they don't, and it's Medicare, their insurance, they don't get any invoices for co-pays or anything related to the terminal diagnosis. All of it, the electric bed that is in the home, all the medical equipment, the medications, all the different different tools we use to manage symptoms are part of the Medicare hospice benefit. So the family is not bombarded with other invoices. Medicare also, Medicaid, there's some patients that are on Medicaid, and that one does pay for room and board in some nursing homes, depending on the situation. But hospice care is paid by Medicare, commercial insurance, TRICARE, and we do fundraise at Coastal Hospice heavily to pay for all those who have no insurance or are underinsured in some way. That's somewhat some of the case. And Dr. Carpenter put on the chat box that concurrent care is available to children. Thank you.
Yes, we have pediatric patients who follow their pediatrician all the time, and the concurrent care is available to them. You're right.
Yeah. So we just want to make sure, this is the goal of our webinar today, is our patient eligible for hospice? So what is eligibility? And I think we've gone over this. We just want to make sure everybody understands is if you would be surprised if your patient was alive in 7 months, more than 6 months, then, and that's an educated guess. And you don't have to, I think Dr. Waris, you were talking about prognostication not being as strong.
Yeah, I mean, they did a study and find out, and what they found out is that the physicians were the worst prognosticators, unfortunately. But that shouldn't disqualify us for doing this. But it's hard to prognose, yeah. But it's a constant thing that you have to look into, and when not insured, yeah, we'll make a referral.
Right, and it's because physicians, nurse practitioners care about the patients. That makes us and makes bad prognostication because the care. But we have some tools. Dr. Carpenter, go ahead.
Well, you know what? I just really quickly wanted to say it's never, it's okay to start the conversation early about hospice. It's okay. If they're not ready for hospice, that's okay. I think it's worse to start the conversation too late. So every time, think about when you make a referral to hospice or when you suggest hospice, it's just to open the conversation. just to talk about it. It doesn't mean that a person has to enroll. So I think keeping that in mind is really important. But please go ahead and talk about this slide.
Thank you for that the conversation earlier is better than late. Thank you for that.
So the different tools that you use for prognostication, there are some core indicators. We use a palliative, or we call palliative performance scale, which is basically just like a lot of the physicians are familiar with Karnofsky scale. That's basically all the palliative care scale is. When the scale is below 50%, it goes from 10 to 100%. 10% is somebody who's almost unresponsive, and 100% somebody is completely normal, and 50% is someone who is mainly bed-bound, unable to do any work, or with extensive disease, they're requiring total care. So when they come to that point, they're hospice eligible. But we are going to share these with you, these scales. When it comes to FAST score is for dementia patients. So anybody with FAST scale of 7 and below would be eligible for hospice. Now, there are some dementia patients who are at scale 6, but if they have comorbidities with the recurrent aspiration and they're declining with weight loss and decreased intake, then they would be eligible to, doesn't have to be, strictly FAST 7. And there's certain lab values, like especially if renal failure or liver failure, and especially the protein calorie malnutrition, if you have albumin of less than 2.5, and you're losing weight and you're not eating, and you don't have other diagnoses, we can use anorexia and cachexia, and they would be eligible, and protein calorie malnutrition by itself. Lately, we're not using they stopped using the failure to thrive and debility diagnosis, but we can use anorexia and cachexia for those patients who are losing weight and they have failure to thrive.
Thank you, Dr. Waris. And this is an old belief that most of the patients who were eligible for hospice were cancer patients. That's no longer the case. Less than 40% of the patients we care for have a cancer diagnosis. You have in front of you all of the other conditions that would bring a patient to hospice.
And we are going to share the criteria for each disease. I don't want to go into the detail of each of them.
Yeah, we are almost approaching the end of our webinar. Dr. Carpenter, do you want to suggest some of these criteria to trigger some of these conversations?
Sure, and I think this really is a nice wrap up, because it's what we've talked about throughout with the disease trajectories and with the progression of people through serious illness, that when there's multiple readmissions to the hospital, and one of our attendees brought this up, that's a great time too to get palliative care involved and to start the conversations. If there's, in the terminal phase, meaning that they are no longer responding and not responding to treatment, that the treatments become more burdensome than it has beneficial. If a person is refusing treatment and saying, I don't want to do this anymore, that's a time to think about talking about hospice services. And when comfort is always our goal, but when it becomes that being comfortable is more important, and being at home or being, in an environment that the person wants to be in instead of the hospital, when that's the goal, then I think it's, time to really talk about how do we meet that goal? How do we make sure that they are getting the care, people are getting the care that they want, and remaining in the environment and the setting that they want to remain in at the end of life.
Thank you so much, both of you, Dr. Waris, Dr. Carpenter. You've been wonderful. I want to thank you. We shared a lot of information for the audience. Please know that Coastal Hospice is here for you. You can call us anytime. Our number is on the screen for you. And you have been a wonderful audience. We enjoyed seeing the chat and all of your comments. Thank you. We thank you. And I turn it to Lauren.
Thank you, Monica. And thank you to all of our panelists, Dr. Ghulam Waris, Dr. Joan Carpenter, and again, Monica Escalante, for this presentation on a topic that may be relevant for many. And thank you to everyone who has joined us today. We hope this information was useful to you. To wrap things up, we ask that you just take a couple of minutes to fill out this short survey. It's only 5 simple questions. Your feedback will help us bring relevant programs to you, your practice, and those you care for. When you click Leave the meeting, you will receive a survey from Zoom. We will also send you the link to the survey in a follow-up email to you. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you can call us at any time on the number on the screen. Thank you once again for joining us today. I am Lauren Blair, and have a wonderful rest of your day.
Thank you.
Thank you.